2022. Dr. Pinjala Ramakrishna, Dr. Harinder Singh Bedi, Dr. Deepak Singh, Dr. Sanjay Desai, Dr. Gulshan Jit Singh, Dr. Roy Verghese, Dr. Shoaib F. Padaria, Dr. Rahul Jindal. Sorry, Dr. Deepak Selvaraj. I now request Dr. Vimalan, Associate Professor of Vascular Surgery of CMC Vellore, to welcome the gathering.
Good morning, everyone. I'd like to thank you all for coming today. It's the second day of Vaicon 2022, and one of the most looked forward part of the program, the Ted King Oration. I'd like to welcome all the dignitaries on the stage. Thank you all for participating in this program. This oration is an important part of VAI because Dr. Ted King was one of the founding international members of VAI, and he's remembered very fondly by everyone. I look forward to hearing from Dr. Pinjala. Thank you, sir, for coming all the way to deliver this oration. I shall now hand over the program to Sister Sheila.
Thank you, Dr. Vimalan. The honor of reading the citation for the Ted King Oration of Vaicon 2022 goes to Dr. Shoaib F. Padaria, the past president of VAI. May I now request you, sir, to please read the citation.
Morning, everybody. Welcome to the annual Ted King Oration. So a few words about Dr. Ted King. You know, Ted King was a true friend and a guide of the Venous Association of India. Dr. Ted King was born in 1955 in Indiana, United States. He completed his medical studies and practiced what is called basic family practice, a general practice, what we call in India, for 15 years in Oak City and Chicago. However, from the very beginning, he had a great interest in the specialty of phlebology. And he did some real pioneering work in the field of laser wavelengths, foam sclerotherapy, and compression therapy in the treatment of varicose veins. So much so that in spite of being a family physician, he was a respected member of the American Venous Forum and the American College of Phlebology. In fact, it was due to his work as a family physician, the American College of Phlebology encompassed not only vascular surgeons, general surgeons, cardiologists, dermatologists, but also family physicians, and encouraged them to practice in the field of phlebology. And why is this important? Because you will remember that the Venous Association of India was also formed on a similar basis to encompass people from all fields in this country, from all specialities who have an interest in phlebology, to learn about phlebology and practice it after having gained expertise. Later on, Dr. Ted King joined as the medical director of the vein clinics of North America, in spite of having a busy clinical practice. For those of you who may not be aware, the vein clinics of North America is a group of around 29 clinics in various cities of North America, all of which practice only phlebology. Each clinic has a group of 8 to 10 doctors practicing phlebology, and one of the largest group practice of phlebology in the United States. Now, Dr. Ted King, along with Dr. Mark Malouf and Professor Uhl, were the earliest of the phlebologists from all over the world who attended our earliest Vaicon conferences. And these three people took it amongst themselves, not only to attend every Vaicon, but to guide us and teach us the nuances of phlebology as we practice today. In fact, the old timers amongst us, we fondly remember these people, and especially Ted King. They went out of their way to teach us everything about phlebology. They pointed out our mistakes, pointed us in the right direction, encouraged us to attend various conferences, seminars, workshops all around the world. And that is the reason the VAI today is one of the leading phlebology societies in the world. When I was the president of VAI in 2013, Dr. Ted King honored the Venous Association of India by giving us a special session at the World UIP Congress in Boston. And that was the first time that 8 of the members of our society went as a group to present our Indian work on the international stage. That was a path-breaking event because following that particular conference, the VAA has been represented at almost every single international conference in the world, and the VAA has made a mark for itself, thanks to Dr. Ted King and his pioneering efforts. On a very personal level, Ted King was an extremely humble man, a very quiet individual. At every conference, he would sit at the last bench, the last seat, with his little laptop, listen to all the lectures that we gave, however basic they would be. At the end of the session or the end of the day, he would approach each one of us individually and point out how we could better ourselves. He would wholeheartedly involve himself in all our activities, and he endeared himself to each and every one he met. Unfortunately, at a young age of 59, he passed away due to cancer in 2015. We lost a good friend, and the VAI lost a mentor and a guiding light. And this oration, the Ted King oration, is a small gesture of remembering a really true friend of the VAI. Thank you.
Thank you, sir. May I now call upon Dr. Rahul Jindal, the past president of VAI, to introduce Dr. Pinjala Ramakrishna. Sorry.
Thank you. Can I have the slides, please? I think Dr. Shoaib Padaria has put it so rightly about him, and in such nice way. And, you know, everybody sitting here, he has, you know, touched us in some way, you know, emotionally and, you know, in education way. Dr. Ted King has been to my home 4 times. And, you know, all of us, you know, has been really touched by his presence, and always smiling and very calm. Actually, only once I have seen him in slight anger mode in so many years. Dr. Pinjala, as you can see this photograph, you know, he has still not revealed his secrets from last 15 years. Why his hair always remains black, ours are receding, and you know, just like Anil Kapoor, he always remain young, I think. You know, we all envy him on this. You know, this photograph you can see it looks same, but actually it's like 14 years apart. So that's what I'm saying. That's the beauty. So, you know, there must be some secret about the research and the things what he do in academics, and it is not publishing it. And, you know, he has been, as you know, all these things you already know about him, academic part. I'm going to tell you about non-academic parts, which you guys may not be knowing about it. So he has published lots of trials, conferences, you know, training courses for nurses, technicians, DNB programs. You know, a lot of laurels for him. On a personal level, you know, he's my senior from PGI. And, you know, I met him first time, you may not remember, sir, in 1998. And I was the senior resident in general surgery. And, you know, introduction to VSI, you know, vascular surgery, should I take vascular surgery or not? And he actually said, yes, it's a very good branch. There were very few people in the surgery. And I actually didn't know anybody in the vascular surgery. And so my senior told me, just go and meet him and he should be able to guide you. His last 20 years, you will see him always smiling, very gentle. Any problem in the VI, so we discuss among ourselves and then we go to him. What is your opinion about it? And he's very punctual. And you'll see in all the conferences, if there are 5 people sitting on the front, he will be one of them. So, which is really, speaks a lot, because he really gives the value to the association. And that he deserves. So, and you will see most of the meetings, most of the photographs in the last 10 years, he'll always in the center of the photograph. So I don't know how he manages it, but he always reaches there. I think we all push you in the center and you're always there. And, which is very, very good. So, he was with the governor. And this is, you will see a lot of similar and familiar faces here. And he's always, whenever we are making some new programs, so this was the launching of the venous ulcer registry, so he's always in the forefront. And, man behind a lot of new initiatives which the VI takes. And this is among his friends. He's very calm on the front seat always. So we are sort of backbenchers. We come off and on, Tarun, all of us, we come up and down. But you will always find him in the front seat. We had a lot of international travel together. So you will see Shoaib, me, Dr. Bedi, we are there always together, and we had a lot of photographs like this, and traveling to different parts of the world, doing meetings and all. And this is another country, as you can see, I am getting old in last 5 years, but you will find him same. Sir, maybe at the end of the talk, maybe give us at least some secrets about it. So he's really friends of friends, really, and really helped us a lot, all of us. And you'll see in a lot of parties, he will wear very bright colors. Red, green, yellows, and which really sets him apart in the whole gala dinner. I was trying to find him yesterday with these colors, but I missed it, I think, sir. And the best thing, you should see him dancing. I cannot put in a lot of videos about him. I have a lot of videos. And, dancing on the stage. So, he really puts his dancing shoes on, and he can really enjoy. And this is with our friend, Dr. Sunil. We were all very, very close, and, really good photographs. And with Tarun here, joining us. And this is with all our international friends, Professor Ul, Sergio, and, he is there in the center. You observed? He's always in the center. I don't know how. So, but this is very important point, sir, you must not have observed. Anyway, sir, thank you for accepting to give an oration on Ten King. And, this is an honor for the VI to have you with us. Thank you.
Ladies and gentlemen, can we welcome Dr. Pinjala Ramakrishna as he delivers the Dr. Ted King Oration. Kindly put our hands together and welcome. Delegates, industry, faculty, I request all of you to kindly come to the hall for the Dr. Ted King Oration.
Yeah. Okay, I have to see that now. I pay my respects to Dr. Ted King, was not only a friend, philosopher, guide, and mentor for many of us in this VSI, Vaicon. And I'm very touched by his teachings. And most importantly, he came to Hyderabad and he lost his luggage in the airport. So he was remembered for the trouble that he has taken on that day to come to Hyderabad for the Venous Association meeting. He is always humble in his expressions, was listening to all of us, and continued to mentor us in all the difficult situations. I thank him for all that he has done to the Venous Association and to the members of the Venous Association. My talk today would be optimization in venous disease diagnosis and management. Science is expanding. Our understanding of venous disease gradually expanding, and so are the measures and methods that we use to diagnose and treat the disease. Venous disease are never-endingly expanding. So it becomes necessary to optimize the techniques that we use to diagnose, treat venous disease. Venous disease, we all know that it could be acute venous disease, chronic venous disease, acute and chronic venous disease. It can be in one leg or it can be in both legs. So, optimization of diagnosis and management methods, which may be basic or advanced methods, should be done to get the best outcomes and also economically viable measures that are possible in our clinical practice. How to maximize the quality of care relies on the physician using his or her expertise in combination with the best available evidence to determine the right management for an individual patient. However, the explosion of knowledge through print and online journals has made it virtually impossible to read all the published literature related to the particular topic or procedure. So came various guidelines, consent statements, and now we have venous appropriate use criteria, venous appropriate AUC, and this is an important step in improving the quality of chronic venous disease care. This has become very important today. What is appropriate use criteria? Appropriate use criteria are additionally intended to help determine if a given patient should receive certain diagnostic test or treatment. AUC use a combination of the best available evidence and expert opinion, but differ from the practice guidelines in two main ways. First, AUC do not require that of the expert panel reach a consensus. Second, AUCs have the ability to address as many permutations of the patient characteristics as desired. The only validated scientific method determining the appropriateness is the RAND UCLA appropriateness method. Dr. Masuda, her co-authors, and the vascular societies who took the high road and addressed both appropriate and inappropriate chronic venous care by producing these AUC. Although the definition of appropriateness can vary from one AUC to the next, Masuda et al. Used the RAND definition of appropriateness. An appropriate procedure is one in which the expected health benefit exceeds the expected negative consequences by sufficiently wide margin that the procedure is worth doing, exclusive of costs. Therefore, these AUCs should be used to guide the treatments by well-intentioned physicians whose goal is to improve the health of the patients with chronic venous disease. So this is the RAND UCLA appropriateness method where the criteria are derived which can be appropriate, uncertain, or inappropriate. This is now the gold standard in assessing the patients whose appropriateness and inappropriateness. Conclusions. The AUC statements are intended to serve as a guide to the patient care, particularly in areas where high-quality evidence is lacking, to aid clinicians in making day-to-day decisions for common venous interventions. This may also prove useful when applied on a population level, such as practice patterns, and not necessarily to the dictate decision-making for individual cases. As product of collaborative effort, it is hoped that this could be utilized by physicians and multiple stakeholders committed towards improving the patient care and to identify and stimulate the future research projects. For example, if you take and look at the role and appropriateness of radionuclide venography, today we know that radionucleography is not practiced anywhere in the country. But if you look back in 1990s, it was considered to be one of the best methods to diagnose venous thrombosis and pulmonary embolism in one test. But today, the appropriateness is questioned. At the same time, in 2006, our friends from Delhi published the data on radionuclide venogram in diagnosing pulmonary DVT and pulmonary embolism. They screened 1,552 patients, out of which 744 patients showed DVT and 294 patients, that means 40% had high probability lung scan. So it was an astonishing fact for many of us to know that patients with DVT will have asymptomatic pulmonary embolism. Unless you evaluate, you may not be detecting the pulmonary embolism. But today, if you look at the appropriateness of this test, it is questioned by many of us. CT angio has become gold standard for diagnosis of pulmonary embolism, and it is available in most of the places. What about catheter-directed thrombolysis? Yesterday, we discussed a lot about catheter-directed thrombolysis and its effectiveness. Catheter-directed thrombolysis, in addition to anticoagulation, has been with us as an adjunct for the last 30 years. And the ATTRACT trial, CAVEN trial have given lots of insights into the understanding of catheter-directed thrombolysis in the management of DVT. The conclusion of ATTRACT trial was, among patients with acute proximal deep vein thrombosis, the addition of pharmacomechanical catheter-directed thrombolysis to anticoagulation did not result in a lower risk of post-thrombotic syndrome, but did result in higher risk of major bleeding. That has put off many people, but whereas this was criticized by those who are practicing. And what about Indian data? I'll come to that slide in a second. The thrombolysis anticoagulation has shown 47% post-thrombotic syndrome, whereas simple anticoagulation showed 48% post-thrombotic syndrome. There is not much difference between these two. But if you look at the bleeding, 1.7% major bleeding in the thrombolysis and anticoagulation group, and 0.3% in only anticoagulation group, suggesting that we have to think the appropriateness of the catheter-directed thrombolysis based upon a ATTRACT trial. At the same time, the data from Indian hospitals have shown this technical success rate of 96% with thrombolysis, CDT, and also the patency has been as high as 80% and so on and so forth. So at the end of the day, they said that PCDT is safe and effective. It reduces the occurrence of PTS with preservation of valve competence and vein patency as compared to the anticoagulation alone. So this is encouraging for some of us who would like to continue catheter-directed thrombolysis. But again, you should look at the appropriateness of this in clinical practice. So this paper was published in Indian Journal of Vascular and Endovascular Surgery. And so the need for venoplasty stenting in PCDT group was also looked at. In 2020, appropriate use criteria for chronic lower extremity venous disease was brought out by a multi-society document. We have been discussing all through about the appropriateness of GSV ablation based upon the SEEP grading, short saphenous vein ablation based upon SEEP grading, appropriate. The green one suggests it is appropriate. The brown one shows rarely appropriate. Red one says never appropriate. So for anterior-axillary saphenous vein ablation, what is appropriate? For perforator vein, treatment, what is appropriate. For stenting the iliac vein, inferior vena cava, what was appropriate was shown beautifully in this slide. So we need to understand the appropriateness and inappropriateness to recommend a treatment for the patient to say the optimization. In a similar fashion, how appropriate we are in giving thromboprophylaxis in trauma patients, DVT patients. So this paper was published in European Journal of Vascular Endovascular Surgery by Agarwal group from Vellore. The incidence of VTE was 17.46 per 10,000 admissions. Malignancy was the most common predisposing factor, followed by post-operative status 30%. The incidence following surgery was 5 per 10,000 operations. General surgery patients had the highest incidence of deep vein thrombosis, DVT, that is 40.3%, while the incidence of orthopedic patients was only 20.1%. It is quite different from what generally is taught and discussed in the Western literature. In Western literature, it is the orthopedic patients who have high incidence of DVT, but it was shown differently in the trial from Indian hospital. Low molecular weight heparin has been increasingly used therapeutically over the years. Pulmonary embolism was seen in 14.9% of the study patients. Mortality in those confirmed pulmonary embolism was 13.5%, which is corresponding with the Vasishtha trial, which was done in PGA Chandigarh autopsy trial. So we have conducted similarly a number of trials to identify the risk of thrombosis in our patients. ENDORS, RELIEF, PROVE registries were done by me in the past. What did we learn from ENDORS trial? ENDORS was quoted very often in the literature. The risk of thrombosis in the patients who were admitted to the acute hospital beds was assessed, and the use of thromboprophylaxis was also assessed. The risk was high, continues to be high in all the countries, including India. Every alternate patient in acute medical care bed is at risk of pulmonary thromboembolism, but only 16% surgical patients, 19% medical patients received thromboprophylaxis. That indicates it is inappropriately treated, and we have to improve the understanding of thromboprophylaxis in our Indian patients. SIP classification. Is it appropriately used in clinical practice? Yes, we know that SIP is mainly followed for clinical grading, that is C1, C0, 1, 2, 3, 4, but the remaining parts of SIP are not mentioned in any time by most of the clinicians who are treating venous disease, except for few specialists like VAI members. Very few people other than this document SIP classification in their clinical practice. Appropriate use of diagnostic measures, very important for optimizing the diagnostic measures. So pre-test probability, various scores are available. Compression ultrasonography, D-dimer, duplex scan come under level 1 evidences, whereas CT, MR, conventional angiograms, ventilation perfusion scans come under special advanced investigations. How far we should evaluate the comorbidities in our patients? What is the optimum diagnosis of these, such as cardiac, renal, pulmonary, hepatic, cancers, vasculitis, collagen vascular diseases, undetected trauma, and hospitalization. All these factors increase the risk of thrombosis, but how far we should investigate and diagnose these conditions? We found out that in a trial conducted by us, indicated that the elderly male patients with a high BMI seem to be at high risk of advanced clinical grades of CVI. The impact of comorbid conditions such as diabetes, hypertension, and hypothyroidism on CVA could not reach significance in the present study. So we found out that the comorbidities do have a role to play, but their role has not been found to be significant in the trial conducted by us. What is the appropriate use of anticoagulation? What is optimal use of anticoagulation? So we need to have net clinical benefits. Number needed to be treated, number needed to be harmed should be coinciding, and we should have more number of patients to be treated to get one harmful effect, less number of patients should be treated to get one benefit. That is what it is. NNTs and NNHs are important to get the net clinical benefit. Anticoagulation, the crucial thing is what is the optimal monitoring, what is the optimum time in therapeutic range, what is the bleeding risk, what is the optimum bleeding risk, what is the duration and what is the optimum duration, and what are about the tests such as TEG. Tests such as thromboelastogram are not appropriate at this time of the clinical status, but in future probably, maybe we will be talking more about thromboelastogram. Currently, the trials that have been done have not been shown to be beneficial in considering thromboprophylaxis based upon thromboelastography. What is the ideal or optimum TTR? 60 to 70% is the ideal TTR time to get the maximum benefit of anticoagulation in our patients to prevent recurrent thromboembolic episodes of pulmonary embolism or sudden death in our patients. We did this trial and found out that those patients who maintained TTRs between 60 and 70 had excellent Villalta scores in the follow-up of the patients. So this paper was published by our group and said that optimum INR values are very important. Optimization of warfarin dose. It is also an important thing, but very few people are doing research in this angle. Pharmacogenomics. Is there any role of pharmacogenomics in deciding the dose, warfarin dose in our patients? I think this trial was also done by us and found out that certainly they are helpful, but appropriateness of this test at this moment is questionable. Very few centers are able to do pharmacogenomics to decide the pharmacological dose of warfarin in the treatment of our patients with anticoagulation. Optimal therapy for varicose veins. Primary varicose veins, secondary varicose veins, post-thrombotic varicose veins, recurrent varicose veins, residual varicose veins. What is the optimum that one would like to do is a question, I think, where we need a lot of research further to understand what is the optimum level of treatment in such different types of patients, or a combination. What is the optimum documentation of venous mapping? I think very few centers are mapping the veins adequately to understand the pathological process that is happening in the superficial system, GSV, above knee, below knee, short saphenous system, perforated system. Proper mapping techniques should be done to get the optimum results and benefits in our treating our patients. Assessment of the treatment, assessment of response to the treatment. How to assess the optimal response to the treatment? The best way to assess the response to treatment is VCSS scores. I think this is also underutilized by our team members who are practicing venous surgeries and venous interventions. So for example, if you see this upper diagram, the venous clinical severity score in this is 8, and after treatment it has become 4. So this is the best way to document the assessment outcomes in treating the patients. As determined by the venous clinical severity score, treatment saphenous vein reflux with endovenous radiofrequency ablation results in clinical improvement by symptoms and aids in the healing of venous ulcers. Age, female sex, and tumescent volume are associated with high success rate of occlusion. They found out that the venous clinical severity score to excellent standalone tool for assessing the outcome after a saphenous vein radiofrequency ablation. So the practice of venous clinical severity assessment before and after interventions becomes essential, and it is still underutilized. We need to improve it to get the maximum and optimum utilization. What about SIP classification? SIP classification and its recent revision are primarily descriptive tools used to classify and categorize the patients on presentation. The SIP classification is relatively static, however, changing little over time, and is a poor method to assess the usefulness of an intervention. So that is why many papers have shown combination of SIP classification and venous clinical severity score is the way to go forward in assessing the patients of venous disease before and after treatment with various methods that we give the patient. Now coming to the optimization of the venous disease assessment treatment, endovenous therapies, thrombolysis plus plasty, thrombolysis plus plasty plus stenting, thrombolysis plus plasty plus stenting plus splinter deployment. Then what is the optimum endovascular therapy? I think we need to assess each individual patient to decide how much is the optimum in this patient, whereas a group will say that I don't want to put a stent, one group would say I would not like to give a lysis. So there are always arguments and discussions like we have seen yesterday, wonderful discussions that have taken place. Similarly, anticoagulation, when to give, how much dose to give, how long we have to give is also important in combination with the therapeutic interventions that we follow. What is the role of DOACs? There are unmet needs with the oral anticoagulants. Those unmet needs are met by the DOACs. So there is a role and optimum utilization of DOACs should be done in the given patient. Thromboprophylaxis, primary thromboprophylaxis, secondary thromboprophylaxis. So is there any role for routine thromboprophylaxis justified in Indian patients sustaining major orthopedic trauma? The answer to this is yes, because the incidence of VTE among thromboprophylaxis receiving group was found to be as low as 8%, whereas it was much higher, 14.49%, in those who are not receiving any form of prophylaxis. Indian patients have definite risk of venous thromboembolism after major orthopedic trauma, and thromboprophylaxis either by chemical or mechanical methods seems to be justified in them. I think this is appropriate to consider in all major orthopedic trauma patients, thromboprophylaxis as a priority. And to improve the outcomes of these patients, we should recommend thromboprophylaxis, and that seems to be appropriate. What about cancer patients? In a similar way, in cancer patients also, it is essential to understand the risk of bleeding and appropriateness of anticoagulation should be considered. Current trends in the duration of anticoagulant therapy is discussed extensively by a number of trials, as you can see here mentioned. And Einstein extension, Amplify extension, Hokusai extension, all these trials have also been helpful in deciding the extent of anticoagulation in current practice. Optimum diagnosis of lipodermatosclerosis. We don't have guidelines to assess the grades of various types of lipodermatosclerosis. We only say about plus or minus lipodermatosclerosis. And what is the optimum treatment or what should be the duration of treatment for lipodermatosclerosis is also not established today in the clinical practice. Compression therapy, a lot has been discussed yesterday about compression therapy. Long stretch bandages, short stretch bandages, non-stretch bandages, pressure graded stockings, and also the wraps. I think extensively discussed by Dr. Rahul Jindal about the wraps and their usage should be optimized in clinical practice to get the best outcomes. The interface pressure measurement is also not practiced by many of us, and it should give the optimum results of compression therapy if you practice that with PICO. What is the optimum therapy in varicose veins? I think now many patients are being given various combinations of therapies, such as endovenous thermal ablation plus foam sclerotherapy plus such as LAFOS, or combination of phlebectomy, surgical therapies. I think what is the optimum we should decide. I think this morning also we discussed, yesterday we discussed perforator, how to manage the perforators. In asymptomatic C1-2 patients, we should not consider dealing with perforators as one of the guidelines that was brought out. In venous ulcers, I think once again, combination of various methodologies will give the optimum results, such as medical therapies, interventions, surgical therapies, and compression therapies. Optimum utilization of the diagnostic measures and the therapeutic measures in venous disease will bring economic relief to the patients and the hospitals, and the resource utilization is going to be better in clinical practice. So at the end, if you diagnose and manage venous disease effectively, adequately, optimally, the sick leaves of the patients will come down, the loss of working hours will come down, and the economic status of the patient and patient family will be much better off. Ladies and gentlemen, I tried to give the importance of optimization of the science that has progressed in understanding the disease, chronic venous disease, diagnosis and management. And to get the best results of our treatments, we should know how to assess the disease, and we should also know how to utilize the resources optimally to get the best and optimal outcomes. Thank you very much.
Please stand up and give a standing ovation.
Ladies and gentlemen, let's rise, put our hands together and give a standing ovation to Dr. Pinjala Ramakrishna. It's now time to honor him, and may I call upon Dr. Harinder Singh Bedi, the President of VAI, to present the plaque of honor to Dr. Pinjala Ramakrishna. Thank you, sir. I now call upon Dr. Roy Verghese, Chairman of the Governing Council VAI, to present the medal and the citation to Dr. Pinjala Ramakrishna. Thank you, sir. Dr. Gulshanjit Singh, Treasurer, VAI, will now present the shawl and the certificate. Remove the shawl. Thank you, sir. Dr. Deepak Selvaraj, Vice President VAI, Deputy Director of CMC Velo, will now propose the oath of thanks.
On behalf of the governing body and the governing council, I wish to thank all of you who have come for this annual conference. The TED King Oration is a very important part of our conference. I thank you all for coming and attending this oration. We will now get ready for the inauguration, and I request all the faculty, delegates, and also the industry to come into the main ballroom.
Ladies and gentlemen, before we head on to the inauguration, we would like to take you through the recap of yesterday's conference and the gala dinner. Let's have a look at the audiovisual and refresh all our wonderful memories that we had yesterday. May I have the video, please?
So here we are at the most awaited occasion of this Vaicon 2022, the inauguration. And may I now call the following dignitaries to please come on stage. Dr. Sanjay Desai, the Secretary VAI, Dr. Harinder Singh Bedi, the President VAI, and Dr. Gulshan Jit Singh, the Treasurer VAI, and Dr. Roy Verghese, Chairman of the Governing Council of VAI. As we begin this inauguration, shall we look to the Lord in prayer? Let us pray. Our Heavenly Father, Lord, we thank you, Lord, for this beautiful morning and for the gift of life, for the gift of knowledge, wisdom, and the dissemination of this knowledge through beautiful conferences such as this. We commit this time of inauguration into your hand. Be with us, O Father, and let your presence guide us. We pray in Jesus' name, Amen. Please be seated. I now call upon Dr. Harinder Singh Bedi, the President of VII, to deliver the welcome address and also give the introduction to the Venous Association of India.
A very good morning, everyone. Respected Chief Guest, sir, dignitaries on and off the stage, and my colleagues. Wish you a very warm welcome. To borrow a line from a famous writer, Charles Dickens, we live in the best of times and we live in the worst of times. A bit contradictory. Worst of times because of the pandemic with its 1,000,001 problems, and the best of times because we as doctors, we as a human race, have found the 1,000,002 solutions, and hopefully we have, defeated the pandemic. Amidst these very, very unprecedented, you could never have thought of what has happened in the last 2 years. In these very unprecedented, challenging times, our association, the Venous Association of India, has firmly engaged itself in providing a continuum to education and guidance in resuming safe surgical medical practice. The theme of our present conference is research and innovation, with an emphasis on translating research into the practical aspects which we can all use. We are focusing on how to do it sessions, interaction with experts, and our organizing team led by a very dynamic Dr. Deepak Selvaraj has been able to get the top leaders in venous disease, both from India and abroad. A little bit about our Venous Association. The Venous Association is a very young and vibrant association, and in a very short span of 15 years, we have grown exponentially, and I'm proud of the fact that the growth has been so rapid and so good that we have a large membership now in this age. And today in front of me are all the leaders, the founders, and all my colleagues who have started, who had the vision to start the Venous Association of India. This conference, it draws upon expertise from across subcontinents, the leaders, as I said, from India and from abroad. And it's a vibrant and relevant scientific program which balances research, innovation, and practice. And the organizers have ensured that every doctor who wants to has access to the best practices and to the best opinion from the leaders all over the world. Now, diverging a little bit, there is a problem we have. When I and most of my colleagues joined MBBS, we entered a profession called medicine. And today, unwillingly, unfortunately, we have entered a business called healthcare. And call me old-fashioned, but I believe we have strayed, and we agree that we have strayed. And with the help of our association, I am sure It will be an uphill task to come back to our primary focus is what? Primary focus is patient care. And I'm sure with our association, which has so many like-minded people, we will come back to our basics. So we want to go far, and to go far, you don't have to go fast, but we have gone fast, but we have to go together. So I'm so proud of all my colleagues, my leaders, my supporters, our members, and I invite all of you to let us join again in this. We had a little gap because of the pandemic, so let us join again in this new beginning. Keep together, not just join, but then keep together to sustain the progress and more importantly, to work together to redefine success. So thank you and welcome once again.
Thank you, sir. Learn from others, work harder than others, but expect less from others. That is just one of the quotes of the motivational heroes of Tamil Nadu, and that is Dr. Sailendra Babu, the Director General of Police, Tamil Nadu. So now may I call upon Dr. Deepak Selvaraj to introduce Dr. Sailendra Babu.
Good morning, ladies and gentlemen, and members of the governing body. I am now going to introduce our chief guest for today. I am delighted to introduce to you our distinguished chief guest for this day, Dr. C. Sailendra Babu, presently designated as the Director General of Police and Head of Police Force, Tamil Nadu. He rose through the ranks of the force, serving variously as Superintendent of Police, Deputy Inspector General of Police in various districts within Tamil Nadu, Inspector General of Police of the Special Task Force in Tamil Nadu as well, and also the Commissioner of Police, Coimbatore City. Following this, he then served as the Inspector General of Police, North Zone of Tamil Nadu, after which he was elevated to the rank of Additional Director General of Police. As Additional Director General of Police, he influenced the reformation of three crucial areas of administration: law and order, coastal security group, and prisons in Tamil Nadu. Prior to his current post, he has also held office as a Director, Fire and Rescue Service, and Director General of Police, Civil Supply, CID, Tamil Nadu. The invaluable reforms that he has introduced to the Tamil Nadu Police Force also merit special mention here. He introduced the camera-based aerial traffic control system in the Coimbatore city and envisioned the concept of a reception officer in all police stations. He also spearheaded the development of cyber investigation teams in 6 northern districts of Tamil Nadu. The unique program, A Day with the Police Commissioner, designed to familiarize school children with the police, was also a product of his innovation. In addition to this, Dr. Sailendra Babu is an eminent member of the academic fraternity, as is evidenced by his illustrious and eclectic educational qualifications. He holds a degree as a Bachelor of General Law, a postgraduate degree in Agriculture, and an MBA as well. He also holds a PG Diploma in Cybercrime Investigations and a PhD from the University of Madras. Moreover, he has also obtained considerable field training by graduating as a commando in the National Security Guards, Black Cats, Manesar. He also has undergone extensive training in the Academy Development Training Program conducted by experts, completed leadership training on the subject, international crime issues, and also attended a top-level management training program, all held in the United States. Additionally, he is also an extremely passionate fitness enthusiast and takes initiatives to educate people as to the importance of the same, online as well as in many motivational books he has written, and he has encouraged children, youth, and also several students across the country. The passion for health and wellness is reflected in his life as well as his work, and he has collected a significant number of high-profile accolades to attest to the same. To elaborate, he has participated in and won the R.D. Singh Cup for swimming and represented India in the Asian Masters Athletic Championship in Bangkok. He has also consistently bagged gold medals at the state shooting competition in 5 separate years and has won the Champion of Champions title in shooting in 2017. Furthermore, he holds an outstanding inventory of personal records to his name. He has cycled 4,200 kilometers from Kashmir to Kanyakumari in less than a month. He swam a length of 28.7 kilometers of the Park Strait from Talamannar, Sri Lanka to Dhanishkodi, India in 12 hours and 20 minutes. And He has run 50 marathons from 2012 to 2019. He has also earned the designation of Super Randonner in cycling, a title that is earned on completion of 200 kilometers, 300 kilometers, 400 kilometers, and 600 kilometers cycling, all in the span of one cycling season within a stipulated time. It is apt that an official of his merit and standing is here with us on this day, and for the inauguration of the 15th Annual Conference of the Venous Association of India, to inspire us with his ideals and motivate us to achieve greater heights. It gives me great pleasure, immense pleasure, to welcome him to deliver the Chief Guest's address. Over to you, sir, Dr. Sailendra Babu.
Thank you, Dr. Deepak Salwaraj, respected Dr. Harinder Singh Bedi, Dr. Sanjay Desai, Dr. Gulshan Jeet Singh, Dr. Roy Varghese, distinguished guests, doctors, ladies and gentlemen. It is indeed my proud privilege to be part of the Venous Association of India. I am particularly happy because this is a gathering of distinguished doctors, and once upon a time, I wanted to become a doctor. Okay? So when you aspire to be a doctor, and if somebody is calling you, inviting you to even address the doctors of very high achievement and profile, that is certainly a great honor. Dr. Harinder Singh Bedi was asking me, like us, are you also a doctor? I told him I am a doctor, but I am not a medical doctor. I am a research doctor. There are officers, there are a couple of police officers. In fact, the officer who is holding charge of this place today is a medical doctor, Dr. Sudhakar, MD. So I sometimes used to think maybe as a compensation. Even when I was very young, maybe 10 years, I wanted people to call me as doctor. That never happened. So at least now let them call me in the same name. And it gives me a profound feeling of satisfaction, except in certain occasions like this, when there is an embarrassment. This is also okay, but I was flying to United States of America. I was almost sleeping, and the air hostess came searching for Dr. Sailendra Babu. Sir, are you Dr. Sailendra Babu? Yeah. Can you help a patient? Somebody needs your help. That is a really, really critical time. It is very, what do you call, very difficult situation. I told I am not a medical doctor, sorry, I am only a research doctor. But I particularly came to this function to just thank you and to appreciate you for all the great services that you are doing to the humanity, which you alone can do and nobody else can do, which is also possible because of your knowledge, your expertise, your skills, and the greatness of the very medicine that you are practicing. I've been a very silent observer of science and the medical the medical science and its development over a long period of time. I was the commissioner of police, and I got a very special request from one of the hospitals. The request is very simple. I must help them to transport a harvested heart from one hospital in Coimbatore to reach the airport in 10 minutes. And I must also coordinate with Chennai City. The moment the heart arrives in Chennai International Airport, I should help them to reach the harvested heart from that place to one of the hospitals in 10 minutes. Okay? Very simple. Even though I'm not a surgeon, I'm part of surgery now. like a nurse or like a technician. In fact, we did it, and I got a call from the very man who survived after the surgery to thank me for the help I had done. If there is a delay of few minutes or an hour or so, probably that surgery wouldn't have gone well. So that is the time we just think that how much the science has progressed, medical science has progressed, medical procedures have progressed, how much the doctors have really acquired the skill of even harvesting a heart of a person and transporting it to a place 500 kilometers away, and to, integrate it into the system of another person and make him live today. Even when I was coming, we were discussing about a case of my teacher, Dr. Jayachandran. He's also not a medical doctor, he's a professor. Dr. Jayachandran is my teacher in this college, and he was also one of the guiding spirit of many students like us, a man with so much interest, an antique collector. He is a man who likes history. He collects plants and animals, a bachelor. He had multiple problems, vascular problems. So only a vascular surgeon can give a solution. Was referred to CMC Vellore with many blocks in the legs, the leg already which is in serious medical deterioration, was restored, and instead of amputation, now he is alive, in full shape, able to walk, thanks to the very high professional, level of high professional competence of Dr. Deepak Selvaraj and his team of doctors. That's another example of how doctors can really, really be of great help to people who are about to die. If you look at the history of India, when India got independence, our total life expectancy at that point in time was 22 years. That means a man born at that point in time, or a woman, can aspire to live for 22 years on an average. That doesn't mean everybody is going to die in 22 years, but possibly we may die. Today it is 69 for men and 70 for women. We have come a long way. So to a large extent, people can live and enjoy life and productive life and contribute to the wealth of the country and to their own family happiness. This is possible. How that is possible? How it is possible? It's only possible because of the medical education, the medical practice, the advancements in medicine, and other supporting factors. But the most important part of this, the very science of allopathic medicine. The very science of allopathic medicine can really work wonders. 194 sovereign countries of the world, they treat, respect, and rely upon only this system of medicine. All over the world, there are systems of medicine, and people of that country or locality have naturally great faith in their own system of medicine. But problem is, many or most or all of these systems actually do not work. That's the problem. Because they are not based on science. The science-based, the research-based medicine was started by William Harvey. The man who was born in 1574. Probably every cardiovascular surgeon or vascular surgeon should recognize him as your hero. This is the first time a man has propounded a theory even without that of a compound microscope. Anthony von Leeuwenhoek's microscope was not invented. But he, to a large extent, predicted that blood is circulating. There are 3 different ways of circulation, or 7 steps of circulation. To some extent, circulation from the heart or from the lungs or the system. He has almost finalized that the blood circulates. So, William Harvey is the first man credited with scientific experimentation in biology, in physiology. He's a great man. So from then onwards, the science has started, grown, and today we are all benefited because of you. In fact, people like me who are otherwise physically active and athlete, we depend upon doctors. To be honest with you, today probably if the allopathic medicine and allopathic doctors like you are not there, probably I will not be alive today to come and talk to you. Probably I would have got a heart attack earlier, much earlier. Probably I would have had some other complication and I would have died. But today, I have complete faith that doctors of today will not allow me to die, at least till I am at the age of 80. I have the full confidence. Okay? They will never allow me to die. Somehow. Unless I am dead, okay? I know I will not die unless I am dead. Okay? That much confidence, that much facility has really come. Annual checkup, you know what is going on, where is the problem. In fact, before every one of my physical endurance, adventure, I go for a series of tests. You all know it. One of the most important, of course, is circulation, whether my circulation is okay. So doctors give me full confidence, okay, you can do this, you can do for this many days, this much distance, this much horse stress. Yesterday I rode bicycle 50 kilometers at a speed of 32 kilometers. On an average, 32 kilometers. Once my cycle went up to 48 kilometers per hour. I saw my heart rate. I can see it here. See, gadgets. It was 171. Now it is 55. So I am myself becoming a doctor of my own system to some extent. So when medicine has grown so much, the problem is it has not even reached most of the people. Most of the people are not able to avail your expertise, your skill, your knowledge. The reasons well known to all of us, Dr. Deepak was also discussing. So I will come to the concluding part of my speech to say that, first of all, you are doing an incredible job, a profound service you are doing. In the meantime, our expertise, which is wealth, it's a great wealth, has not reached the last man. And doctors must really think over it. I have seen a lot of doctors so compassionate. Many of them you will find in CMC Vellore, of course, who will work for the least of the salary, for the best of the services. I know, if I can offer, if there are any number of hospitals who can offer 5 to 10 times more salary to Dr. Deepak, but he won't go. I don't know why he doesn't go, I don't know. There is something. I don't know, what is that? What is the commitment? Is it a commitment because this institution has made him a big doctor? Is it a commitment that a lot of people are really still poor? Is it a commitment of a particular ideology which he has taken up? Or is it a question of his principle? You know, all of us have principles in life. That's very important. Attitude and principles are very important. I really don't know. But I've seen many such doctors. Some of my relatives are working there. So, long time before I asked the doctor, how much are you being paid? He said, sir, I'm getting 40,000 rupees. Doctors of his caliber, I know, are being paid 10 times more. But they won't go. So it is this kind of a commitment to the society, the doctors. The original, I don't know, Hippocrates' oath also involves the doctor should not even look for profit or some kind of great kind of income. So we certainly have a group of highly dedicated. I am still wondering, when young people, I am one of those people who really spend a lot of time with young people and write for them, speak for them, spend time with them. Many of them say, sir, I want to be an IAS officer because I want to serve the public. Service. This word is very common, Serve the nation. This is more popular. I want to become a doctor because I want to help the poor people. This is a general statement, very general statement. But how many of them really go back and serve the people? Governments once said the doctors must go to the villages and serve for 1 year. Next day there is a nationwide strike by the doctors. But we see still people, service-minded, service organizations, still going to the village. The doctor I was telling, Dr. Jayachandran's own sister, was living in a place, in a village, part of the, what is the hospital? Rainy Hospital, in a village. She has a postgraduate in medicine and she was living there. Even before, 100 years before, there are institutions in the same place. In fact, she was one of those legacy of that same institution. 100 years, even now it is a very small place. I still wonder, 100 years before, how doctors from England came and lived there. How they thought service is most important than your own life. In fact, I come from a place, there was a doctor who lived entire life for the people of the place. His name is Dr. Samuel. Dr. Howard Vincent Samuel, I think. Dr. Samuel. Yeah, I was very young, I didn't know. Much later, I came to know it is because of this doctor, several young people got inspired and they studied, and then they went for higher studies, they became doctors. Samuel became the role model, he was a hero, he was an icon. He was a hero otherwise also. Then I Googled and found out this man was not originally a doctor, he was a sportsman. He came to India, of course he's a doctor, medical doctor of course. His passion was not medicine, his passion was to climb Mount Everest. And in 1924, he climbed Mount Everest along with Mallory, who's still missing, whose body was recovered only a few years before. Mallory died, this man survived. So he came back, almost made it. Maybe 50 meters, 100 meters. All of them died. He has survived, he came back. He came to Travancore. He found how people are dying of cholera, how people are really dying of leprosy, suffering from leprosy, one of the most deadly diseases. And people really wanted his service. He went to England, came back as a doctor. The rest of his life, he lived there. In fact, his son himself worked in the CMC Vellore later. And he is an Olympic medalist for this achievement. He was given Olympic medal, if you can Google, maybe 1924 or 25. So this man's book, one of the most popular book, I will certainly encourage you, buy this book and read it. The name of the book is Knife and Life in India. Very interesting. Whatever he has observed about the patients, about the co-doctors, about the fake doctors. One of his assistants became the most popular doctor in the whole place after that. He said, I learned all the techniques from Samruel. I am better than Samruel. He was more popular. More people are going to his hospital. He was only a nurse, trained by Dr. Samruel. How people can be interesting, interesting characters. You now will find out. Your own drug man will be acting as if he is chief of the CMC Vellore. Right? Human behavior. So, he says that every day he used to see 150 patients. And in the afternoon, he may have 9 surgeries, of which generally 2 to 3 people die in the surgery table because of the cancer. The people have at that place, jaw, cancer of the jaw. He says sometimes this chloroform is not available, it's in short supply. Elder brother does a surgery, who goes back home, he brings 3 more brothers for the same surgery. And the doctor says, this time chloroform is not available, we'll get it only next month. Sir, don't worry. Without chloroform, please perform. It is unbearable. So he performs surgery without anesthesia. Lot of interesting stories. He's one of the next book is very interesting, After Everest, after Mount Everest, mostly in the same theme. So I'll just conclude saying that what Samruel has said, he is part of the mission called Church of South India, medical mission. They say at that point in time, in 1925, they have treated 1.5 million people in that particular locality, southernmost corner of India. 80% of the people who have come from Gujarat, Maharashtra, Karnataka, even now, don't think that CMC Vellore people are coming from Gujarat and West Bengal and Assam now. No, even earlier. Even in 1925, this is the case. So, he has left a message to the young doctors, his juniors. He said, do the most you can, do the best you can, and more importantly, speak the least that can be talked about it. Thank you very much. Wish you all the best.
Thank you, sir. To signify the inauguration of Vaicon 2022, may I now request the dignitaries on the dais to light the Kuttuvilakku. May we all stand for the rendering of the Tamil Valthu after the lighting of the Kuttuvilakku. We'll now have the rendering of the Tamil Thai Valthu. May I request the audience to please stand. We'll have the rendering of the Tamil Thai Valthu by the vascular nursing team of CMC Vellore.
நிலமடந்த திகழ்வரத கண்டமில் தெக்கணமும் அதிசிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திரும்பி அந்த செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you. It's been such a honor to have you here. And may I request Dr. Roy Verghese to honor Dr. Sailendra Babu. Thank you, sir. Dr. Sanjay Desai, the Secretary of VAI, will now propose the vote of thanks and conclude the inauguration.
Good afternoon. Thank you, sir. First of all, thank you for not choosing to become a doctor and going on with your service and inspiring people and generations to come. Thank you very much, sir. An idea inspires, a thought inspires an idea, and an idea changes a person, and a person changes a community. I think his books on physical fitness, his personification of walk the talk, he just not writes the book, he does what he means, and he inspires a community. Thank you for that, sir. Thank you again for inspiring the new generation and the generation to come with your books on everybody can become an IPS officer. Like he says he wanted to be a doctor, I think a lot of us here would always say that we wanted to be somebody in the uniform. So we always have that passion. So thank you very much, sir, for that. I know you're very short on time. Thank you for your time for this conference for us to be a part of this and grace this occasion. And definitely you've been very inspiring. While I was sitting there, I said, next time I should ask Deepak to have him deliver an oration or a talk in general to inspire the generations to come, and especially for vascular surgeons like us to come. Ramba Ramba Nandri, sir. Thank you.
Thank you, sir. We will now stand again for the national anthem.
Thank you so much to all our dignitaries on the dais. Thank you to our today's chief guests for taking time out and joining us here. Let's give a big hand to all of them. Thank you, Dr. Sailendra Babu. Thank you to all of you. Thank you for joining us here today. Thank you. Thank you so much, Sheila, for taking us through the proceedings. Without further delay, we would like to move ahead to our next session. And the next session chairperson is Dr. Prakash Ramamurthy. May we have you on the stage, please? Dr. Prakash Ramamurthy, and the panelists are Dr. Chitra, Dr. Sharmila, Dr. Amalur Pavanathan J. I'd also like to request Dr. Nihar Ranjan to please join us on the stage, and Dr. Balakumar S. to please join us on the stage. The topic of discussion, the topic for this particular session is venous ulcer. Venous ulcer, chaired by Dr. Prakash Ramamurthy. Over to you, sir.
Check. One of the most anticipated sessions of the conference. Venous ulcer burden is a very big burden for the community, and I have had patients whose marriages have broken up. One patient whose marriage was fixed, the bride refused to get him, get married, and a lot of social issues are there. So we are very keen to see what our panelists are saying. Most of the panelists are going to be online. I think Nihar may be the only one who is going to be offline. Going to do the live presentation.
Meanwhile, we'll just take a moment and request all the rest of you to kindly be seated. Those of you who are in the groups, you are requested to please take your seats. Requesting all of you who are moving around in the hall to please take your seats. In due respect to our speaker, chairperson, and our panelists, I would like to request all of those who are standing and probably moving around to kindly be seated. Please take your seat. Thank you. Thank you so much. Over to Dr. Prakash Ramamurthy. Over to you, sir. Over to the chairperson.
The first presentation is by Dr. Wool. Are we going to have it online live or have it recorded?
Virtual.
Hi everybody. First of all, I would like to send my warm regards to all my Indian friends, and very sorry and be very sorry not to be with you in the Vaicon. This talk is about the transosseous perforated veins of the knee, and you can find it in Flevo Lymphology. It is published online. The bony perforated veins of the knee are commonly responsible for reticular veins around the knee, but they are underdiagnosed by the sonographers, and they could explain why the injection of these cosmetic lesions are frequently leading to recurrence. The aim of this talk is to bring anatomical evidence of these perforators, which are frequently missed by sonographers. So outline will be anatomy first, then CT venography, duplex color, and finally discussion about phleboarthrosis. So anatomy